Hello everyone, my name is Deema. I'm a fourth year medical student, and today inshallah I'll be explaining to you guys the temporal region lecture as well as the growth features of the cerebral cortex. But first of all, we will definitely focus on the temporal region. Now, usually an important disease that arises here is a disease known as epilepsy, and it's very worth mentioning it while we're talking about the temporal region. And we usually use epilepsy and seizures interchangeably. However, we need to know that epilepsy is the brain disease where the nerve cells, they do not signal properly, so there is an issue in our nerve cells, so they are not signaling the way that they should. So what will happen? This will cause definitely seizures, which is an outburst of uncontrolled electrical activity, which is definitely dangerous. And this can affect obviously the person's behavior, awareness, and also the body movements. Now, how temporal region is related to epilepsy, and why do we have to mention it here? Now, because the most common type of epilepsy usually involves the temporal lobe, and also also epilepsy usually targets specific areas in the brain which are found in the temporal region, such as the hippocampus, parahippocampal gyrus, as well as the amygdala. Now, we know that epilepsy is not our main topic here, but like epilepsy, we know that it is usually treated in most of the patients with anti-epileptic drugs, and we know that epilepsy is not a curable disease. However, we can manage it successfully with these anti-epileptic drugs. However, some patients, they do not benefit with it, so they have a resistant type of epilepsy, or we can say a severe type of epilepsy that is not relieved by medications. So in this kind of epilepsy, we do a more invasive procedure, which is known as the temporal lobectomy. So what do we do in this procedure is that the temporal lobe is assessed surgically and part of the bone is removed. So we remove part of this bone in order to help the patient live a normal life and try to manage his condition. Now, as well as we have something so important which is known as the temporomandibular joint. Now, this joint is a common place of arthritis, and it can present with otitis media, which you will be taking in the special senses lecture, as well as symptoms of toothaches. Okay, so now we'll be going to the mandible, and obviously we know that the mandible, we have the external surface as well as the internal surface. So let us focus now first on the internal surface. We have something known as the condylar process. Now, the condylar process, we need to know that it consists of the head, which is this area, as well as the neck, which is here. And in between the head and the neck, we have a fovea, or fossa, you can say, which is the pterygoid fossa. And as well as we have the coronoid process. Coronoid process is located in front of the condylar process, so they're opposite of each other. And as well, we have the same features on both sides. And for the condylar process, we know that the condylar process, it forms something really important, which is the joint that we talked about, اللي هو TMJ. And how does it form it? By articulating with the mandibular fossa. Now, so we also have the ramus of the mandible, the angle, as well as the body. Now, on the interior lateral surface, we have the mental foramen, which is also an opening and gives passage to two structures, اللي هما mental vessels and nerve, and you can also see them here, the mental vessels and nerve, and you can see that this red circle is the mandibular tubercle, and the lower edge is the base of the mandible. Now we move on to the internal surface. Now, the internal surface, an important landmark that we have is the mandibular foramen. The mandibular foramen, it acts like a canal where structures can pass through it, such as the inferior alveolar nerve and the vessel. Now, we'll be talking more about the nerves in the upcoming slides. However, the inferior alveolar nerve, we need to know that it ends as the mental nerve. And also below the mandibular foramen, we have the mylohyoid groove. And I think by the name, it's clear that mylohyoid groove, it gives passage for nerve to mylohyoid muscle. And you can also see that we have basically near the myeloid groove, we have a bony protrusion known as the lingula. You can see it here. This is the lingula. It is near, as you can see, the myelohyoid groove, and it's usually there is like a protrusion in the lingula. And also we have something known as the sublingual fossa, and the sublingual fossa, it contains a gland, and this gland is known as sublingual salivary gland, and the submandibular fossa also contains a gland which is known as the submandibular salivary gland. So we have two glands that we can visualize in the mandible. We have the submandibular salivary gland and also the sublingual salivary gland. Now, in the digastric fossa, I'm pretty sure the name kind of clicked a bit. So we have a digastric muscle, and we know that the digastric muscle, it has an anterior belly and posterior belly. Now, the anterior belly usually is attached to the digastric fossa. So the digastric fossa, it gives attachment to the anterior belly of the digastric muscle. And also you can see that the symphysis menti, the posterior part usually of the symphysis menti, it has tubercles or spines, and we call them genial tubercles. We have two superior and two inferior genial tubercles. Now I also attached this image that you can find, and now we'll be talking about the muscles of mastication. We have four muscles of mastication: the temporalis muscle, masseter muscle, lateral, and medial pterygoid. Now, the muscles of mastication is also known as the chewing muscles, and I'll be talking about each and every one of them in details, but let's just take an overview. So the thing that they have in common is their action. All of the muscles of mastication are responsible for side-to-side movement, and this is for the grinding of the food. And they all arise from the first pharyngeal arch, and they are supplied by branches of the mandibular nerve. Now, you may wonder, why would a group of muscles arise from a single nerve or supplied by a single nerve? The reason being is that because they have a common embryological origin. Now, you can also relate the mandibular nerve to the facial nerve, where the muscles of mastication are similar to the facial muscle. The only difference between the facial muscles and the muscles of mastication is their supply. Usually they are supplied by the mandibular nerve. However, the muscles of the facial muscle, they arise from the second pharyngeal arch, while the muscles of mastication, they arise from the first pharyngeal arch. So let us talk about each and every one of them in details. To begin with, we have the temporalis muscle. Now, as you can see here, the temporalis muscle, it has a fan-shaped appearance, and it is located on the side of the face, or on the side of the head, sorry. It is located on the side of the head, and the function is that it elevates power elevation. So basically it elevates the mandible. And what do you mean by elevating the mandible? It means closing the mouth. So it closes the mouth. And also retraction. The retraction, however, and what do you mean by retraction? It is basically it's pulling the jaw backwards. Now, retraction is not an action of all of the temporalis muscle. So only the posterior fiber is responsible for the retraction. So not the whole temporalis muscle. Definitely side-to-side movement. And the nerve supply is deep temporal nerve. Moving on to the masseter muscle, and it is also one of the hardest muscles of the body. And it is a very superficial muscle. You can see here it has two heads. It has a superficial head and also a deep head. You can see this is a superficial head, and deep to it is the deep head. And usually the action of this muscle is very strong elevation. So it's a powerful elevation. Now, we also mentioned that the temporalis muscle also has the function of elevation. However, the elevation is minor compared to the elevation that is caused by the masseter muscle. And we said that it's responsible for strong elevation, and it is also, as I said, the hardest muscle of the whole body. So elevation, we said that it closes the mouth and it is supplied by the masseteric nerve. Now for the lateral and medial pterygoid muscle, so let us first speak about the medial pterygoid muscle. So the medial pterygoid muscle also has two heads. So it has a superficial head and a deep head, which is deep to it. And I'll be talking about how to differentiate between the medial and the lateral pterygoid. So for the medial pterygoid, it is located inside the jaw. And just one thing to add on the masseter muscle, that it is the main power muscle for chewing. So this is also a point that's worth mentioning, that it is the main power muscle for chewing. Anywho, let's just get back to the pterygoid muscles. So we know that the medial pterygoid is located inside the jaw. It's a deep muscle, so it's not a superficial muscle like the masseter muscle. Now, the action for the medial pterygoid: elevation, side-to-side movement, and it is supplied. The side-to-side movement, this is, as I said, common, as you can see, and it is supplied by nerve to medial pterygoid. Now, moving on to the lateral pterygoid and how do we differentiate between the medial and lateral pterygoid. So you can see that the fibers of the medial pterygoid, it runs horizontally. You can see that it runs horizontally. However, the fibers of the medial pterygoid, it runs vertically. I don't know if I mentioned horizontal to the medial or lateral, but just again, the fibers of the lateral pterygoid runs horizontally, while the fibers of the medial pterygoid runs vertically. And their function, as I said, elevation, side-to-side movement, that's for the medial pterygoid. And you can see that it's vertically, however, you can see it's more of an oblique. Now, how do we test for the lateral pterygoid muscle? Now, for the lateral pterygoid muscle, you can test it by asking the patient to open their mouth against resistance. This is how you can test for the lateral pterygoid muscle. And the lateral pterygoid muscle, an important point about it is its function, because it has a kind of unique function, which is depression. So it causes depression and protraction. So depression, it opens the mouth. Elevation, meaning closing the mouth. So lateral pterygoid is responsible for depression, which is opening the mouth, and protraction. Protraction is basically pushing the jaw forward. Okay, so now we'll be talking about the arteries and the nerves that are present in the mandibular and temporal region. So first of all, to begin with, we have the external carotid artery. We are on the left side, that's why we have the left external carotid artery. Most importantly, we know that the external carotid artery, it comes from the common carotid artery, which gives rise to the external and internal carotid artery. Now, we need to know an important point where the external carotid artery bifurcates. Now, the external carotid artery, it bifurcates at the level of the neck of the mandible. So behind the neck of the mandible, you will see the external carotid artery bifurcating into two terminal branches, which is the superficial temporal artery and the maxillary artery. So basically, it passes upward through the parotid gland, and it ends by giving two terminal branches. And then let us focus on the maxillary artery. So the maxillary artery, it will give us the inferior alveolar artery. Now the course is the same for the artery and the nerve. So the same concept is applied. So for the inferior alveolar artery, it will enter through the mandibular foramen and exit the mental foramen as the mental artery. So the same thing applies here for the nerve. It enters through the mandibular foramen and it exits through the mental foramen as mental nerve. Now we also have the facial artery. The facial artery, it's very unique and it's easy to identify. So basically, you can see that the facial artery, it loops under the base of the mandible. So you can see it looping under the base of the mandible into the interior aspect, and it supplies the muscles of the face. Now, what happens if the maxillary artery is injured? So if the maxillary artery is injured, we will have to ligate part of the external carotid artery that is proximal to the maxillary artery, because there are anastomosis between the external carotid artery and the internal carotid artery, so there is no danger in ligating the external carotid artery. Now all of the nerves the nerves are all branches of the mandibular nerve. We also have now the auriculotemporal nerve. So the auriculotemporal nerve is deep to the condylar process, and it becomes superficial. So it goes up, you can see it becomes superficial, and it continues upward toward the auricle. Inferior alveolar nerve, coming back to it, so we said it enters through the mandibular foramen and exits the mental foramen as the mental nerve. But before that, it branches into the incisive nerve and ventral nerve. So incisive nerve, as you can see here, this is the incisive nerve, and the incisive nerve supplies the incisor from the name. The mental nerve, it supplies the skin of the lower lip and chin. So the skin over the lower or the skin of the lower lip and chin is supplied by the mental nerve. Now the inferior alveolar nerve, it gives a branch before entering the mandibular foramen. So before it enters the mandibular foramen, the inferior alveolar nerve, it gives a branch called mylohyoid nerve. From the name, it supplies the mylohyoid muscle and the anterior belly of the digastric. Now we also have the lingual nerve. A lingual nerve, you can say that it is basically on the inner surface of the gum of the teeth, I think. And the lingual nerve, it passes near the lingula, and it is found at the medial side of the root of the molar teeth. And the clinical importance of the lingual nerve is that it can be you can cut a piece of the lingual nerve during, for example, wisdom teeth removal or violent extraction of the tooth. Now, a common site for anesthesia during wisdom teeth removal is the inferior alveolar nerve. So it's a common place where the anesthesia is inserted during the procedure of wisdom teeth removal. So you will not feel the pain, but on the second day you will start feeling the pain. Okay, so now we'll be talking about an important joint, which is the TMG. Now for the TMG, we have something known as the auricular tubercle, which is this one. The auricular tubercle, an important part about it is that it prevents dislocation of the condylar head during protrusion. And as you can see, we have, obviously the TMG is reinforced by 3 extracapsular ligaments. We have the lateral ligament, the sphenomandibular ligament, and the stylomandibular ligament. I think by the name, you can also know why is it named in this way. For example, the stylomandibular, because it connects the styloid process to the mandibular foramen. And then we also have the sphenomandibular ligament, which is starting from the sphenoid bone and attaching to the lingula and the edge of the mandibular foramen. Moving back, we know that during, for example, older age, mostly in older age, the ligaments become weaker. Now, TMG, we know that there is something known as TMG arthritis. So sometimes a patient might come to you and tell you, for example, I have a chronic headache. So you do your investigation, there are nothing to be, for example, a warning sign or any obvious cause. But most of the time it is a common cause of hidden chronic headaches. So for example, if a patient came to you with a chronic headache, and also, for example, telling you, for example, I'm hearing a noise during the movement of the joint, these are also signs of TMG arthritis. Also keeping in mind that TMG, it is a synovial joint, and we know that TMG is divided into 2 compartments by the articular disc. So the 2 compartments, so you can see it's divided into 2 compartments. We have the upper joint cavity and the upper compartment and lower compartment. The upper compartment is responsible for protrusion and retraction. However, the lower compartment is responsible for depression and elevation. A common pathology that arises with the TMG, other than TMG arthritis, is dislocation of the TMG. So dislocation of this joint, known as interior dislocation, and it is caused by different mechanisms. For example, fractures of the mandible. We'll be talking about the fractures of the mandible in a minute. Arthritis, definitely. Blow to the chin, for example, when the mouth is opened, so when the patient is opening their mouth and then suddenly something very strong hits the mandible, obviously it can cause dislocation of the TMG. And excessive contraction of the lateral pterygoid muscle. So what will arise from as a consequence of these, for example, traumatic event? So as a complication, there is something known as locked jaw, which is basically the patient is unable to close his jaw. It is basically painful. The pain would radiate to the nearby structure, and surgery sometimes is done. Basically, for the surgery, you need to be very careful because of the close relation of the facial nerve and auriculotemporal nerve. Now, for example, blow to the chin as a cause. A blow to the chin, usually it is caused, for example, during boxing, if the mouth is opened. Arthritis, we know arthritis, it leads to inflammation, which leads to joint weakness. So, and the radiating pain, we said that the pain radiates to nearby structure, and this is because of the masseter. Masseter, it causes further contract. So now we have also, how do we treat it? Obviously, we know the consequences, we know the causes. Now, how do we treat it? So for treating it, we usually give muscle relaxant. So there's also a maneuver that we do, is you put your fingers in the molar tooth. So you can see that the doctors or the physician, 2 fingers is placed on the molar tooth, and you have to hold and take down the mandible, so the head will be below, and then you push back and close. So it's not an easy procedure. That's why we give a muscle relaxant, so the masseter can relax and the patient will not feel that uncomfortable. So before that, we have to go with the fractures of the mandible. Now, mandibular fracture, there are many fractures that can happen to different parts of the mandible. So we have, for example, condylar fracture, and the condylar fracture is the commonest one. It is the commonest one. We have the angle fracture, which is this one, the angle fracture, the body fracture. These are different fractures that can happen to the mandible. But the coronoid process is the reason why the coronoid process is the least one to be, or not likely to be fractured, is because it's protected by the temporalis muscle, and that's an important point that we should also note. Okay, so now we'll be talking about the trigeminal nerve, and from the name tri, it means that it has 3 nerves, and it will give us 3 divisions, which are, or 3 branches. We have the ophthalmic division, the maxillary division, and the mandibular division. Ophthalmic division, it passes through the superior orbital fissure, and it is only a sensory nerve, so it's not a mixed nerve. It gives sensation from the forehead, scalp, and eye region. And the maxillary nerve, it is also only a sensory nerve, so it's not a mixed, and it passes through the foramen rotundum. This is important. Foramen rotundum, it is a foramen that is present in the skull, and I'm pretty sure you guys studied the foramens. So maxillary division, or the maxillary division, it passes through the foramen rotundum. It gives sensation to the cheeks, upper lip, upper teeth, and part of the nose. Now for the mandibular division, the mandibular is a mixed nerve, so it is composed of both sensory as well as motor. So for the sensory part of it, it gives sensation from the lower lip, chin, jaw, lower teeth, and only the front 2/3 of the tongue, but not taste, so it's not responsible for taste sensation. For the motor part of it, it moves the muscles of mastication اللي هم that arise from the first pharyngeal arch اللي هم المسيتر, temporalis, pterygoids, mylohyoid, and anterior belly of the digastric. Now moving on to the nerves. Now we know that the mandibular nerve, it exits the skull through a foramen known as the foramen ovale. The foramen ovale is present in the base of the skull, or you can say it is present in the roof of the infratemporal fossa. It's a infratemporal fossa. It's a fossa that I believe there is a separate lecture about it. Now we have obviously the mandibular trunk. The mandibular trunk, it will give us two branches. We have nerve spinosus, and also nerve to medial pterygoid. Okay, so nerve spinosus, it goes back to the skull to supply the meninges. Now the nerve spinosus, it also goes through a foramen known as foramen spinosum along with the middle meningeal artery. So it goes along with the middle meningeal artery, which supplies the meninges. Now the nerve to the medial pterygoid, it gives a branch which goes through the otic ganglion. So basically it gives a branch, as you can see here, that goes through the otic ganglion to give us two branches, which are to give us or to branch into tensor palatii and tensor tympani. Now also the mandibular trunk, it will give us two divisions, the anterior division as well as the posterior division. Now the interior division is mostly motor, because it has three motor and one sensory. So it give طبعا the interior division, it will give us three motor branches and one sensory. The motor are the masseter nerve, the deep temporal nerve, and also the nerve to the lateral pterygoid. These are motor nerves, and the sensory nerve we have is the buccal nerve. Buccal nerve is the sensory nerve. So the masseteric nerve, obviously it supplies basically it gives it supplies the masseter muscle. Deep temporal nerve is basically to the temporalis muscle. Nerve to pterygoid, lateral pterygoid, it supplies the lateral pterygoid muscle. And the buccal nerve, we know that it is facial, and it supplies basically the soft cheeks. So the buccal nerve, because it's sensory, so it does not supply the buccinator muscle, it supplies only the soft cheek. The posterior division is mainly, as you can see, this is the posterior division. The posterior division is the opposite of the interior division. So the posterior division is mainly sensory, so it will give us three sensory branches and one motor. So we have auriculotemporal nerve, and it gives sensation from the ears, from the temple, and it also carries secretomotor fibers to the parotid gland. We have the lingual nerve. The lingual nerve, it gives general sensation, like for example touch, pain, temperature, and the front 2/3 of the tongue. And as you can see here, it joins with the chorda tympani. It joins with the chorda tympani, the chorda tympani from the facial nerve, which adds taste sensation. So basically, chorda tympani is responsible for the taste sensation, and parasympathetic supply to the submandibular and sublingual salivary gland. Now we have the inferior alveolar nerve. Inferior alveolar nerve, it enters the mandibular canal to supply the lower teeth, and before entering, it gives off nerve to mylohyoid, which is basically motor to the mylohyoid and anterior belly of digastric, and at the chin it comes out as the mental nerve, supplying the lower lip and chin, and basically the skin of the chin. Now the mandibular nerve, let us talk about it more. So the mandibular nerve, we know that it exits the skull through the foramen ovale, and the effect of damage is loss of sensation, flaccid paralysis of the muscles of mastication, and deviation of the jaw to the paralyzed side, and hyperacusis. Now we'll be talking about the reasons Okay, so now we'll just continue with the mandibular nerve. So we said that the mandibular nerve, it exits the skull through the foramen ovale. The effect of damage is that it causes loss of sensation, flaccid paralysis of the muscle of mastication, and also deviation of the jaw to the paralyzed side. So the jaw will be deviated to the paralyzed side. And also it will cause hyperacusis. Now, why it will cause hyperacusis, which is increased sensitivity to sound? Now, it happens because of paralysis in the tensor tympani muscle, and we know that the tensor tympani is supplied by a branch from the mandibular nerve. And what's the relation of the tensor tympani? Like, what does it have to do with hyperacusis? Because the function of the tensor tympani is to dampen the loud sound. So if it's paralyzed, that means the sound would seem very, very loud. And how do we test for the mandibular nerve? By asking the patient to glitch their teeth, and you palpate basically the side of the mouth, as you can see here, by asking the patient to glitch their teeth. Now, moving on to the last part of the lecture, and by the way, this is important because it came to us in the mid-unit. So they asked about the contents of the temporal fossa, so you have to be aware of them. So now let's talk about the petrion. So petrion, it is the weakest yet the thinnest part of the skull, and basically in order to locate the petrion is you have to place one finger behind and two fingers above, as you can see here, one finger behind and two fingers above the, now this is the zygomatic arch, so above the zygomatic arch. And the clinical importance of the petrion is that if this art, if it's ruptured, that means it can lead to epidural hematoma. So, and what runs beneath the petrion is an artery known as the middle meningeal artery. So middle meningeal artery, it runs beneath the petrion, so we need to be aware of its location. And as you can see here, the petrion, it's like an H-shaped junction on the side of the skull where the frontal, parietal, temporal, and the greater wing of the sphenoid bones meet. So it's like a meeting point. And it is located behind the temple, so it is the weakest point of the skull, and obviously making it a crucial area for anatomical landmarks and a site prone to rupture. Basically because we said that the middle meningeal artery, it passes beneath it, so any rupture can lead to epidural hematoma from head trauma. And this is it for the temporal and mandibular lecture. It's very brief, so definitely you guys have to go back to the lecture, but this is just a revision and it helps you clear out a couple of things. I hope you guys understood this lecture. Now we will move on to the gross features of the cerebral cortex. Okay, so now we'll be talking about the gross features of the cerebral cortex. But first, let us just review our knowledge about the cerebrum. So the cerebrum, it is the largest part of the brain, and we know that we have two cerebral hemispheres. So we have the left cerebral hemisphere and the right cerebral hemisphere. As you can see here, there is a longitudinal cerebral fissure incompletely separating both of the hemispheres. You can see them more, you can see it more clearly in this image. And we also have something known as the sulcus and gyrus, sulci and gyri. Now, sulci is the depression, as you can see here, or the groove, while the gyri is the elevation, which is, you can see also the folds. So as you can see here, these are the sulci, while these elevations are the gyri. And then we have the corpus callosum. So this green thing is the corpus callosum, as you can see here, connecting the two hemispheres together, so that, for example, the right knows information about the left side. So this is how the left hemisphere knows informations about the left hemisphere, and this is because of this bridge, which is the corpus callosum. And now we'll move on to the lobes and borders and poles. So the cerebral hemisphere is formed of 3 poles, 3 surfaces, 5 borders, 5 lobes. So let us start first with the surfaces. So we have the medial surface, the superior lateral surface, as well as the inferior surface. Now, for the medial surface, you have to know the landmark. So for the medial surface, in order to know that you are viewing the medial surface, you have the corpus callosum over here. So the corpus callosum, it would help you know that you are viewing the medial surface. Now we have the superior lateral surface and the inferior surface. So the inferior surface of the brain, it's divided into two parts. So we have the orbital part, which is anteriorly, and we also have the tentorial part. So orbital part and tentorial part. Okay, so now we go back to the poles. So we have three poles. We have the frontal pole, the temporal pole, and the occipital pole. And then moving on to the lobes, we have the parietal lobe, occipital lobe, limbic lobe, temporal lobe, frontal lobe, as well as the insula. Now the insula, it is a hidden part, as you can see here. The green part, this one is the insula. Now the insula, it's the hidden part of the cerebral cortex, and it lies deep in the floor of something known as the lateral sulcus that we will be discussing in a minute. It is seen only when you separate the operculum. So you cannot see it if the folds are, if we don't separate it, we wouldn't be able to see the insula. So you have to separate it in order to see the insula. And it is important because it is considered the gustatory area. Now, okay, so now we'll be talking about the sulci. So we have four main sulci of the brain. So we have the central sulcus, you can see it here. So we have the central sulcus, we have the lateral sulcus, we have also the parieto-occipital sulcus, as well as the calcarine sulcus. Now the calcarine sulcus, it is the deepest sulcus. So as I said, we have four main sulci in the brain. The calcarine sulcus is the deepest. Now let us talk about each sulci more in details. Now let us start with the central sulcus. So it starts, as you can see, the central sulcus, it starts at the superior medial border, so just behind the midpoint between the frontal and occipital poles, so just in the midpoint between them, and it descends on the lateral side. And what does it do? It basically separates the frontal lobe from the parietal lobe. So it separates the frontal lobe. Wait, let me just change the color. So it separates the frontal lobe from the parietal lobe. And for the central sulcus, if we dig deeper into it, we will know that it will give us something known as precentral. Basically here we have the central sulcus. Now this is the central sulcus, and in front of it is the precentral sulcus and postcentral sulcus, and each sulcus will be accompanied by a gyrus. So here we have, as I said, the precentral sulcus. This one is the precentral gyrus. So this is the postcentral sulcus. This is the postcentral gyrus. So each sulcus will be accompanied by a gyrus. Okay. Now the central sulcus, it doesn't join the lateral sulcus inferiorly. So there is also something known as I said, the pre-central sulcus, which is in front of the central sulcus, and the post-central sulcus is behind the central sulcus. So you can also draw a 3 parallel lines. I don't know if I attached it here or not. Okay, but you can actually draw a 3 parallel lines. So you can you can draw a 3 parallel lines, so you can also identify the central sulcus and precentral sulcus. And here you can also see that the precentral sulcus, it will give us superior orbital sulcus and inferior orbital sulcus. So this is the superior orbital sulcus, this is the inferior orbital sulcus. As I mentioned again, each sulcus is accompanied by a gyrus. So here will be the superior frontal gyrus, middle frontal gyrus, and inferior frontal gyrus. And now we'll move on to the lateral sulcus. So the lateral sulcus, it has a stem, which is, we can see it clearly here, yeah. Just a second. So we have a stem, and then we also have 2 rami, which forms like a V-shaped. We have the interior ramus and the ascending ramus, and we also have the posterior ramus. Now, usually it separates the frontal and parietal lobes from the temporal lobes. So you can see that it separates the frontal lobe and parietal lobe from the temporal lobe. And usually it's basically a continuation, it's a continuation of the stem. So these anterior rami and posterior ascending rami and posterior rami, they are continuation of the stem. So now we discussed the central sulcus. We said that we have precentral sulcus, postcentral sulcus, and they are accompanied by their gyri. And you also mentioned that the precentral sulcus will give us superior frontal sulcus and inferior frontal sulcus. We'll be also talking about the pars orbitalis in a minute, but let us just talk about now the parieto-occipital sulcus. Parieto-occipital sulcus, just I'm going to give you a brief info about it, is that it appears small in the superior lateral surface because it's mainly present on the medial surface, and that's why. And it usually separates the parietal and temporal lobes from the occipital lobe. So you can see that it separates the parietal lobe and the temporal lobe from the occipital lobe. Now let us talk about the lateral sulcus more in details. So we said that, or we go back to the parieto-occipital sulcus, because there's the calcarine sulcus. So the calcarine sulcus, it is mainly seen in the medial surface, and it extends to the lateral surface. So this is the calcarine sulcus. So you can see that they form like a U shape. The parieto-occipital sulcus and the calcarine sulcus, you can see that it forms like a U shape. And both sulci, you see that it forms like a Y letter. Now let us talk about the lateral sulcus and what does it contains. So here, for the basically for the lateral sulcus, we know that the anterior ramus and the posterior and the ascending ramus, they form like a V shape, and here they are, as you can see, interior ramus of the lateral sulcus, so they are sulcus. So sulcus always accompanied by a gyrus. So here we will have the orbital part of the inferior frontal gyrus, and here we have the triangular part of the inferior frontal gyrus and the opercular part of the inferior frontal gyrus. The orbital part, which is this one, it lies anterior to the anterior rami. So it lies, as you can see, this is the anterior rami, and it lies anterior to the anterior rami. Triangular part, you can see that it lies between the ascending and the interior rami, so it's between them. And then we have the opercular part, it lies posterior to the ascending rami. Now let us talk about the temporal. So for the temporal lobe, it has two sulci, and you can see that, one second. Okay, so it has two sulci, the superior temporal sulcus and the inferior temporal sulcus. So three gyri are formed. You can see that again, sulcus always accompanied by a gyrus. So above the superior temporal sulcus, we have the superior temporal gyrus. In between, we have the middle temporal gyrus and inferior temporal gyrus. Okay, so now we'll be also talking about the parietal lobe. Now for the parietal lobe, we have, as you can see here, the post-central gyrus. It lies between the central sulcus and the post-central sulcus. Now for the parietal lobe, we have the intraparietal sulcus. The intraparietal sulcus, you can see that it separates the superior parietal lobule and from the inferior parietal lobule. So they are separated by the intraparietal sulcus. Now the intraparietal sulcus, it extends from the post-central sulcus. So it just extends from the post-central sulcus anteriorly to the parieto-occipital sulcus posteriorly. So the lobule is the same thing as the gyrus. It's just the names are used differently. Okay, so now we'll talk about the supramarginal gyrus and the angular gyrus. Now, at the posterior end of the lateral sulcus, we will have, as you can see here, at the posterior end of the lateral sulcus and the superior temporal sulcus, there are two important gyri, which are the supramarginal and the angular gyri. So the supramarginal, it is around the posterior end of the lateral sulcus. So as you can see here, it's around the posterior end. So this is the posterior end of the lateral sulcus. We will have the supramarginal gyrus, and for the angular gyrus, it is around the posterior end of the superior temporal sulcus, which is here. Okay, so now we'll talk about the cingulate gyrus, corpus callosum, etc. As I said, the characteristic feature or the landmark of the medial surface is the corpus callosum. So you can see here, and this is, as I said, the connection or the bridge. Now, the corpus callosum, it lies inferior to the callosal sulcus. So as you can see, this is the callosal sulcus, this one, and below it is the corpus callosum. And then we also have the cingulate gyrus. The cingulate gyrus, it lies superior to the callosal sulcus. You can see it lies above it, and inferior to the cingulate sulcus. And this is the cingulate sulcus. As you can see, cingulate sulcus is located above the cingulate gyrus. Now, the posterior end of the cingulate sulcus, it ascends upward to join the superior border, and just in front of it you will find the superior end of the central sulcus. We also have the calcarine and parieto-occipital. Now, calcarine and parieto-occipital sulcus, they are very deep, and they can be seen from the medial surface. We have the cuneus. Now, the cuneus is the area that lies in between. As you can see here, it's a U-shaped or a U letter, and in between it we have the cuneus. The cuneus, as I said, it lies in between them, and it is considered part of the occipital lobe. And then we also have the precuneus. So the precuneus, it is the area between the cingulate sulcus and the parieto-occipital sulcus, and it is considered part of the parietal lobe. For the lingual gyrus, which is here, the lingual gyrus, it looks like a tongue, this part. And the lingual gyrus, it is the area that is located inferior to the calcarine sulcus. So this is the calcarine sulcus. Inferiorly, we will have the lingual gyrus. Now, paracentral lobule, it surrounds the superior end of this is the paracentral lobule. As you can see, it surrounds the superior end of the central sulcus. And we also have the medial frontal gyrus. The medial frontal gyrus, it's in the medial surface of the frontal lobe. So this is, let us say, this is the frontal lobe. So it lies in the medial surface of the frontal lobe. Now, moving on to the end of the slides. So the orbital part, as I said, the inferior surface of the brain is divided into the orbital part and tentorial part. So the orbital surface, it lies in the roof of the orbit. We have something known as the olfactory sulcus, which is this one, this black arrow here. This one is the olfactory sulcus, and basically interior to it is the gyrus rectus. Now, gyrus rectus, it lies medial to the olfactory sulcus, and you can see that the orbital sulcus, it's an H-shaped. To me personally, it looks like a chromosome, as you can see. So to me personally, it looks like a chromosome. However, I just go by the H shape, and it divides the inferior surface of the frontal lobe into 4 areas. So we have the interior, the posterior, the lateral, and the medial orbital gyri. now moving on to the tentorial part. So بالtentorial part طبعا it is obviously the inferior surface of the temporal and occipital, and it lies on the roof of the tentorial cerebelli. And one also important thing that I'd like to mention is, in order to locate that you are in the inferior, or that you are on the posterior side, basically is in order to locate the posterior side, you can see the cerebellum. So in order to know that you are, for example, in the back, is by locating the cerebellum. So this is the cerebellum, so that means that this is the posterior part and this is the anterior part, which is the frontal. So we talked about the orbital part. Now let us focus on the tentorial part. So just to revise the orbital part, we talked about the olfactory sulcus, the gyrus rectus, the orbital surface, and orbital gyri. Now let us talk about the tentorial part. Now we'll be talking about the sulci and gyri. So the sulci, from the medial to lateral, we have the hippocampal sulcus, and the hippocampal sulcus is the most medial one. And the second sulcus we have following the hippocampal sulcus is the collateral sulcus, which will continue as the rhinal sulcus. So the rhinal sulcus is just a continuation of the collateral sulcus. So this is the collateral and this is the rhinal sulcus. And then you also have the occipitotemporal sulcus, which is this one. This is the most lateral sulcus. And the occipitotemporal sulcus, it will give us lateral occipitotemporal gyrus and medial occipitotemporal gyrus. But let us move on back to the hippocampal sulcus. So we talked about the sulci from medial to lateral. We also have gyri from medial to lateral. So the most medial one, obviously, would be the parahippocampal gyrus. So as I said, sulcus followed by gyri. So this is the hippocampal sulcus. This is the parahippocampal gyrus, and then as a continuation we have the uncus. So it's the interior extension of the parahippocampal gyrus. And we also have you can see that the occipitotemporal sulcus, it will give us lateral occipitotemporal gyrus and also medial occipitotemporal gyrus, which is also known as the fusiform gyrus. So the medial one is located above the occipitotemporal sulcus, so it's here, so it's above the occipitotemporal sulcus, and the lateral occipitotemporal gyrus is located below the occipitotemporal sulcus.
Assalamu alaikum everyone, Mohamed Atef here from batch 2027 with a new video from Pacademia regarding the week 4 revision for year 3 neurology or neurosciences. And today we will be talking about the functional localization of the cerebral cortex, the 2 lectures. Inshallah, we'll make them pretty easy. So yeah, let's go through them. So just before we get started, let's know what we will talk about today. So for today, we will be talking about the different functions of the brain regions and what damage to each of these regions can lead to clinically. So before we get started, we need to know some specific terms. First of all, the term lateralization, which from the word, I guess you could understand it, lateralization, which means pertaining to one side. So our brains are have different functions sort of in some of the lobes or some of the regions depending on which side the region is in, okay? So you know the word right dominant and left dominant, like right-handed people are usually left dominant in terms of the brain, and left-handed people have a right dominant brain. That's usually the case, and that's what we mean here by lateralization. So when we mean the dominant hemisphere, we mean the hemisphere which pertaining to these functions. We also need to know something known as the sensory motor hierarchy. Just keep in mind it's how a stimulus, it starts with a stimulus which gets understood by the different regions in the brain, primary regions, followed by secondary regions, which are known as association regions. And then it goes to like for a motor action, the sensation finishes, and then we integrate the information, and then we bring out a response, which is usually from a primary motor region and a secondary motor region. Again, we will go through it now. And there is this picture in the lecture. I just took it straight away from it. I would say don't yeah, focus on it a bit. It has historically been a bit annoying for us, but just know it in basic detail. That's all, as mentioned in the lecture. So you need to know like that the brain, usually most of the cortex is formed of 6 layers, except 2 regions, which are again mentioned in the lecture, involving olfaction and involving the hippocampal formation. So going through the first lobe, which is the occipital lobe, and I have the eyes here for you to remember. The occipital lobe is formed mainly by the primary and secondary visual cortices. And what you need to know here is in the medial side, in the medial view of the brain specifically, there is this fissure in the middle of the occipital lobe called the calcarine fissure, which separates superiorly the cuneus from inferiorly here, the lingual gyrus. And you need to keep in mind that the primary visual cortex is around this area of the calcarine fissure. So it surrounds the calcarine fissure above in the cuneus and below in the lingual gyrus. And then there is the secondary visual cortices, which are the rest, which form a lot of the rest of the occipital lobe. And what you need to know is um, the primary visual cortex. It's primarily involved in like interpreting or like seeing what you're actually seeing. Okay, so if we have damage in the primary visual cortex, we would actually turn blind. It's important to also know, but this will be covered in more detail in special senses, that which area of the primary visual cortex corresponds to which type of blindness. So our vision is kind of crossed. So for example, if you see something that's in the upper right visual field, that would translate to the lower left area of the primary occipital cortex. That's the area where it will be seen in the brain. So a damage, for example, here we said the lingual gyrus is the inferior. So a damage in the primary visual cortex in the area of the lingual gyrus, that's on the left, in the left hemisphere of the brain, would lead to loss of vision in both eyes, in the right superior um, quadrant of vision. So if we can divide the eye into like 4 quadrants of vision, it will be the left lower area damage in the brain would lead to right upper loss of vision, and so on for each of the different areas. Again, no need to know much about it now, but it will be covered in more detail in special senses. That's what's called, if a whole area, both superiorly and inferiorly, are damaged, like the whole left primary visual cortex is damaged, then we would have something known as a crossed homonymous hemianopia, which is basically this half of vision in both eyes is lost completely. And if it's the right, then the left is affected, and if it's the left, then it's the right affected. And finally, if the secondary visual cortex is affected, is damaged, then it would lead to something called visual agnosia. And agnosia means not understanding the sensory information that's provided to you. So you would see, but you would not understand what you're seeing, if that makes sense. Again, because the second visual cortex, it like forms connections and relates things to one another, and that's how you understand what you're seeing, while the primary visual cortex just lets you see what you're seeing, if that makes sense. Following that, we will go with the temporal lobe. Again, it's a bit more complicated than the occipital lobe, but not as complicated as the parietal lobe, but we will get through it. So the temporal lobe, again, I've put an ear here and a face that's speaking to remember that the temporal lobe is primarily responsible for hearing and understanding speech, which I will show you now. So basically, in the middle of the superior temporal gyrus, there is in the middle of the superior temporal gyrus, there is a primary auditory cortex. And the primary auditory cortex, just as the primary visual cortex, it's the area that lets you hear what you're hearing. It gets information from an area in the thalamus known as the medial geniculate body. Again, this will be covered more in special senses. But what you need to know is the primary auditory cortex is there. And damage to up one side of the primary auditory cortex, so the left one or the right one, will lead to slight bilateral deafness. So it wouldn't cause complete deafness in the other ear. Keep that in mind because there is information from both ears going to both hemispheres, unlike the eye, where like the left is only going to the right and the right is only going to the left. So keep that in mind. Again, will be covered more in special senses. However, while it would lead to less hearing in both ears, it would actually cause inability to localize sounds in the contralateral ear. So if the left primary auditory cortex is affected, then the right, you would not be able to localize sounds on the right, from the right ear. So keep that in mind. The second thing is the secondary auditory cortex, which is formed from the remaining parts of the superior temporal gyrus. Like the secondary visual cortex, this is the area where it integrates information about what you're hearing to let you understand what you're hearing. There is one more. There are two more areas actually. The first one is the facial recognition area, which you need to see the medial side of the brain. Like this is the outside, this is the inside. So you need to see the medial side of the brain to see it. There is this area known as the fusiform gyrus or the medial occipitotemporal gyrus. It's the same name, and this area is responsible for facial recognition. So if you recognize someone, for example, your friend, um, you know how your friend looks, and you can link that to their name, to all the information you know about them. So if you have damage in this area, what happens is something known as prospagnosia. And this is when there is bilateral damage, so in both sides of the fusiform gyrus. And that means basically facial blindness. So you would not be able to distinguish between faces. Finally, there is perhaps the most important area here in the temporal lobe, and it also takes some areas of the parietal lobe. What this area's name is Wernicke's speech area, and it's only found in the dominant side. Keep that in mind. So if someone, most of the time, if someone is right-handed, then the dominant brain hemisphere is the left hemisphere of the brain. So Wernicke's area will only be found in the left hemisphere. And where in the left hemisphere of the temporal lobe specifically, it will be found in the posterior parts of the superior and middle temporal gyrus and the inferior parietal lobule. So in area around here, basically, if you see this, you can mark it easily by seeing this M-shaped um, um, area here in the inferior parietal lobule, this M-shaped area. This area is formed from both two gyri known as the supramarginal and angular gyri. And these are the two gyri that form the inferior parietal lobule, and they are part of Wernicke's area. And then the rest of Wernicke's area is in the posterior part of the superior and middle temporal gyrus. So right about here. So this whole area. And why this area is very important is Wernicke's area is responsible for comprehension of language and sensory speech. So if there is damage in Wernicke's area due to a stroke that affects this area, for example, and later you will be able to, inshallah, link how a stroke in a specific artery affects this area and this area. If it's affected, then this happens. So when Wernicke's area is affected, what happens is something known as sensory or receptive aphasia. So the person can speak, they can speak fluently, but the problem is they cannot understand what you're telling them. So they will have difficulty comprehending sound. They can hear you, but they cannot make sense of what anything's being said is, even by lip movement. Moving on, we have the parietal lobe, and the parietal lobe, I would say the most high yield area to know in the parietal lobe is the primary somatosensory cortex, which is this area right here, formed from the postcentral gyrus. And you really need to know how damage in this area can affect the body. So a lot of stroke patients present with damage to this area, and this area is responsible for most of the sensation, for understanding or like recognizing most of the sensations in the body, including proprioception, cutaneous, and vestibular sensation. So this area is not only from the outside view of the brain here, or the exterior lateral view of the brain here, it also extends in the medial area of the brain. So you would find it here as well, going inside. And what we have here is a somatosensory or motor homunculus, which basically correlates to, okay, if there is damage in this area, for example, this corresponds to damage here, which means that the area that will be affected, so you will lose sensation in it if you have damage here, would be the contralateral tongue and lips, for example, or here, when you go medially, it's the lower limbs. So what you need to know, you don't need to memorize every single thing here. What you need to know generally is uh, from the exterior, here, the most inferior and exterior aspect is the most superior part of the body. So it would be affecting the lips and mouth and eyes and nose and stuff. And then the more medially you go here, so until you go deep in the middle of the brain, in the midline, that's where you'll find the lower limbs. So it goes from above to below in this fashion, okay? So you would expect how damage in the medial area here, for example, would lead to contralateral loss of sensation in the lower limbs, while damage here would lead to contralateral sensation of the face or the upper limbs. You need to keep that in mind. There is also the secondary somatosensory cortex, which integrates information understood from the like the information gathered from the primary somatosensory cortex, again like the other secondary areas. And there is another area you need to know about, which is a bit deeper, called the insula. And the insula basically is an area where it's not really a loop. It's sort of one. It's where gustatory sensation is sensed or recognized. And gustatory, what I mean here is basically the taste of food and so on. Then you have the somatosensory association cortex. And the somatosensory association cortex is particularly important. Why is that? Well, because the somatosensory association cortex is responsible for stereognosis, which can be tested when someone especially presents with a stroke, for example. So what stereognosis means is if you close your eyes and hold an object, for example, a Rubik's Cube, and you can feel it, you can know it's a Rubik's Cube, right? Someone with damage to the somatosensory association cortex cannot understand what they are feeling without opening their eyes. So they would have astereognosia, all right? Above astereognosia, they would have agnosia, which is inability to understand or make sense of different sensations they are feeling. And then they will also have apraxia, which is difficulty or inability to coordinate specific, like, in specific, um, how can I say it? We could say specific processes. Yeah, that's the word I'm looking for. So something that involves multiple processes, multiple steps in terms of sensations, they will not be able to make sense of it. Again, we also need to know, as I said in the previous slide, there is Wernicke's area is also here in the inferior parietal lobule, especially in the supramarginal and angular gyri. And Wernicke's area again is responsible for multimodal sensory stimuli. So in terms of the inferior parietal lobule, which is this area right here, if there is damage to the supramarginal area, again, this is pretty specific, but it's mentioned in the lecture, so it's good to know. If there is damage in the supramarginal gyrus, which is a part of Wernicke's area here, then this damage would lead to something known as idiomotor and buccofacial apraxia and sensory apraxia, and they would have aphasia as well. This aphasia is particularly known as conduction aphasia. So what you need to know is there is part of the arcuate fibers that's going through this region of the brain, and the arcuate fibers connect this Wernicke's area to something called Broca's area, which we'll discuss in the next slide. and damage to this area will lead to impaired communication between them. And that would basically manifest clinically as poor repetition. So you tell the patient to repeat specific instructions or words, and they will not be able to repeat these words after you. Then there is the angular gyrus as well. And the angular gyrus, what you need to keep in mind is it also sort of contains a bit of important information, and this information can be disrupted in damage to this area. So a damage in the angular gyrus of Wernicke's area would manifest as something known as Gertzmann syndrome, which is not common, but in this syndrome is characterized by agraphia, alexia, dyscalculia, finger agnosia, and right to left confusion. So it's pretty much a big syndrome, but what it means here is you won't be able to write, you won't be able to read, you won't be able to perform simple mathematical calculations. Differentiating between the different sensations in the different fingers would be lost, and the patient would classically present with right to left confusion, which is they cannot distinguish between something in the right and the left in terms of their body. Finally, we go to the frontal lobe, and the frontal lobe is pretty big. However, I would say it's more simple than the parietal lobe, which involved a lot of yapping from my side. So, the primary motor cortex is the main area, just like in the parietal lobe, the primary somatosensory cortex was the main area of discussion. Here is the primary motor cortex is the primary area of discussion, and it's formed from the precentral gyrus. So, the postcentral gyrus, which is found more posterior to the central gyrus of the brain, contains the primary somatosensory cortex, the primary motor cortex in the precentral gyrus anteriorly. It also contains part of the anterior part of the paracentral gyrus. And this primary motor cortex is responsible for voluntary skillful movements for pretty much everywhere in the body except the eye. So keep that in mind again for special senses. Inshallah. So you would understand that damage to the primary motor cortex would lead to paralysis, basically, or hemiparesis. And it's same to the somatosensory cortex, where we have the homunculus thing. It's the same thing here. So damage more medially would lead to paralysis in the lower contralateral lower limb, while damage more externally here, so in inferiorly and externally here, would affect more of the upper limbs and face. There is also the supplementary motor cortex, which is important for planning complex movements, particularly with the hands. Keep that in mind because the hands require fine coordination. There is also the premotor cortex, which is not it is also responsible for planning movement. However, it's responsible for movements of the extrapyramidal system, which again you will discuss later in your course. But what it basically means is it's not really fine movements. It's the extrapyramidal system is responsible for muscle tone, reflexes, and so on. So damage in this area would be responsible for damage in errors or increased muscle tone and reflexes, and it would also lead to the return of infantile reflexes, which are inhibited usually by this area. So this area is not well developed in infants, and that's why they have the suckling reflex, for example, or the grasp reflex. And damage to this area would lead to the return of these reflexes to adults. We also need to keep in mind that here in the center of the middle frontal gyrus, you would find something known as the frontal eye field, which is responsible for voluntary eye movement to the opposite side of the frontal eye field. So contralateral voluntary eye movement, conjugate lateral movement to be specific. So it is responsible of, for example, when you look to the right, both your eyes go to the right at the same time, and they use a different set of muscles, and this area coordinates that basically, only in the lateral movement. So you would imagine that if this area is irritated, and when an area of the brain is irritated, it usually fires more in terms of the nerves and stuff, then both eyes would look opposite to the, will be locked into looking to the opposite sides of the region. So a right frontal eye field irritation would lead for both eyes to keep being locked in the left, looking to the left. However, if damage happens, then you won't be able to lock both eyes in the opposite direction and they would be looking at the same side of the lesion. So damage or death of the left frontal eye field would lead to the eyes continuously looking at the left, or like at least in the lateral position. Uh, finally, before finally, actually, we have Broca's area, which I hinted about in the last slide. Broca's area is basically the Wernicke's area best friend, but it's much more anterior. Specifically, it's in the triangular part of the inferior frontal gyrus, only in the dominant hemisphere, just as Wernicke's area. And you need to keep in mind that this area is really important because damage to Broca's area would lead to something known as expressive motor aphasia. So Wernicke's area lets you make sense of what other people are saying. However, Broca's area lets you speak or express yourself to a certain degree. So basically, it helps you articulate your words. So, as someone with damage to Broca's area would not be able to express themselves, and you will often find them after a stroke. You will find them really annoyed because they know what you're telling them, but they cannot speak or tell you back what their response is. So that's how to differentiate from Wernicke's from Broca's. And again, as I said, the arcuate fibers is between them, connecting them for communication, and damage to this would lead to something known as conductive aphasia with poor repetition. Finally, you need to keep in mind that there is a prefrontal cortex, which makes up a huge part of the frontal lobe. And this area is basically what differentiates us from animals. It's very developed in humans, and it's really responsible for decision making, for social inhibition, for short term memory, and a lot of functions, and integrating a lot of sensory and a lot of information in general in our brain. That's what makes us human. Damage to this area could lead to like severe deficits, as there is evidence that damage to this area may lead to ADHD-like symptoms. Again, we are not really aware of a lot of the things of the brain, to be honest, but what we know for sure is this area is really important in making us what we are, humans. And we can remember in the Quran, ناصية كاذبة خاطئة. Again, some people explain that by ناصية, which is the most frontal area of the brain, the prefrontal cortex here. That's what some people explain it as, some scientists. Because it's responsible for decision making. That's the area where you basically developing or like formulating the notion of flying. So that's a nice thing to keep in mind. And with that, we are done with this heavy lecture. I hope you have enjoyed. I would say it's one of the most important lectures you will ever face. So keep it in mind, keep revising it. You will keep going back to it, especially when going to clinicals, even when you see like patients with stroke and stuff. You need to localize these things. And you won't go straight away for an MRI or CT in a lot of the cases. So you need to keep that in mind. And it would make you a really a really smart doctor, and you will stand out, of course. And that's pretty much it. I hope you enjoyed the lesson, and yes, see you later.